Good afternoon, my friends. Today we are going to talk about CBCT anatomy and incidental findings. We will understand what cone beam computed tomography anatomy looks like and what are the incidental findings. And this session will be a very valuable tool for your clinical practice. And we will review some of the technology we have discussed before. Let's go forward. So today the objective is to understand the CBCT anatomy of the head and neck region and to appreciate the incidental findings in CBCT scans because you're legally and morally responsible for all your CBCT scans. And we will also check the clinical application of CBCT in dental practice. And even if you're going into residency programs or you're going into general dentistry practice, it'll be very, very useful for all the specialties. Just quick review. Last time we discussed about the three planes, the axial, coronal, and the sagittal. Axial means from superior to inferior or goes from inferior to superior. Sagittal means you go from side to side or left to right. And coronal basically means it goes from front to back or anterior to posterior or posterior to anterior. So that is about these CBCT scans. So you have to really know in 3D imaging, these three pearls are very useful for you. And for this case, for the axial images, you may have in your exam question too. I will pull up three images and I say, which one is the axial one? Which one is the coronal one? Or which one is the sagittal one? So they'll be in your midterm or final exam. So basically anterior means front, posterior means back, and this is the left side, that's the right side. And this is just a volume rendered images, so you can see kind of Ceph, but what you really need is axial, sagittal, and coronal. You need them. And you have superior, you have inferior, you have anterior, you have posterior, so you can see that too. Yeah, again, in the coronal view, you have superior, inferior, left, and right. This again you will have in your exam question. I'll ask you what's the difference between the CBCT reconstructed panoramic radiograph and the regular 2D imaging radiograph, panoramic radiograph. In CBCT, you can make the pan of your dreams. So you can basically you can make a pan where there's no artifact, where there's nothing, so there's all the artifacts are gone from this area. So you can do that one. And you don't have spine artifact. You get a very beautiful CBCT image and you can reconstruct your pan from that. Likewise, you can also make your lateral Ceph, and you can also make your cross sectionals, and you can do wonders in those images. This is about the CBCT anatomy of the TMJ, temporomandibular joint. So you can see here this is the condyle right side, and this is the condyle left side. And as you see, there are 6 green lines: 1, 2, 3, 4, 5, 6. And these are the parasagittal views: 1, 2, 3, 4, 5, 6. So I'll ask you, I'll put one of the images and I say select the parasagittal view, and you have to select these views for the TMJ. And likewise, same thing. You can see 1, 2, 3, 4, 5, 6. These are the 6 parasagittal views. You can see that. And TMJ anatomy, as you know from the skull, you can see that you can see the you can see the condyle here, and you can also see, if you go a little bit more anterior, you can see that coronoid process, and this is the glenoid fossa. You can see that, and this is the diagram of presentation of the condyle, and you can see this is the disc, DISK, and this is the glenoid fossa, and this is actually the lateral pterygoid muscle, which is the superior portion, which is attached to the disc. Exam question will be what is the muscle? What is the lateral muscle which is attached to the disc and the core and the condyle? You can say condylar neck. The answer is lateral pterygoid muscle. So that will be your exam question. Basically, TMG is a beautiful relationship or a beautiful friendship between the glenoid fossa, TMJ, the muscles, the disc, and then the condyle. So everything works together in a very synchronous way, in a very friendship way, and that's how you can see that. And in 2D images, as you know in your pan radiographs, this is the glenoid fossa. You can see that, And this is the mandibular notch or the sigmoid notch. They also call it depression. Whereas in CBCT, you can actually see this glenoid fossa very clearly, and you can also see the condyle here very beautifully here. So that's pretty good. This is on the, this is on this, parasagittal view, and there's the coronal view. You can see very beautifully. And here you have a depression too. This depression you have to, see, and that's beautiful. And the pan one, I just want to show you. I'm sure you have taken many pans till now you have reached fourth year. So doctors, you can see this is the depression of the sigmoid notch. They also call it mandibular notch. And just some anatomy. This is the condylar head and condylar neck. You can see, and whenever there's a fracture, you can see the condylar neck fracture. Okay. And this is the axial view. You can see there's a right side. Yeah, this this is the right side. There's the left side, and you can see the parasagittal view, and there's a paracoronal view. And likewise, this is the other one. This is a coronoid process. You can see on the diagram here where the blue pencil is showing. That is the coronoid process. You can see on the right side, and that's on the left side, and that's how it looks on the sagittal view. And on the pan, it looks exactly like this one, right? That's pretty good. For the TMJ, I want to tell you a short story. Our country here in the United States, we spend about $26 billion for for getting treatment for the TMJ and for all the insurance and everything. We spend a lot of money in that. And there's a beautiful country in the subcontinent in Southeast Asia. It's called Bhutan. There, the entire GDP or the gross domestic product for for the country to run, it's about 2.6 billion dollars. So we are spending about 11 to 12 times more money only on TMJ compared to this country runs entirely on 2.6 billion dollars to run the whole country, and we spent 11 times more money on non-production. That means we still cannot find solutions for these TMJ issues. So it's interesting. Look at the scenario, look at the scene. That's pretty beautiful. Yeah, it's very beautiful. It's also eco-friendly country, carbon zero they call it. You can see people walking here. These are all this this Himalayan kind of flag. That's pretty beautiful. Okay, let's go next. So on the pan, I want to show you. You have seen that on the pan, it looks the condyle kind of looks like this, whereas on the on the CBCT scan on the coronal view, the condyle looks like this. So this actually, you can see there are two condyle, which shows like a peace sign. So that is the condyle on the right side. You can see, and that means it happens sometimes because of the trauma at the time of delivery. They also call because of when there's a forceps delivery when the baby is born. So that time when they hold the head, that time they injure that area. That's why they get a trauma, and that's one of the theory they call it. And on the axial view, you can see this TMJ. You can see it's bifid condyle, basically like peace sign. It separates into two. So if you look at back in your pan where you're trained to look at your condyle, it shows two areas which are like peace sign. You can see that. Now, if there's a trauma on the TMJ, these are called cross-sectional images. So you put your line on the TMJ. There you can see 5 different green lines. 1, 2, 3, 4, 5. Each line resembles each cross sections. 1, 2, 3, 4, 5. And that means usually your condyle should be smooth, roundish, nice. In this case, you can see it looks like a camel head. That means there's a fracture on the condylar head, and since there's a fracture, the condylar head is pulled by the lateral pterygoid muscle medially, and that's why you see this condylar head. Most of the time, you don't have to treat these things. It just fuses over time, and yes, you do have a problem with the joint and the temporomandibular joint disorders. So it is very interesting how they treat these things. So basically, they don't do any surgical intervention in this area. So this is an exam question for you. So which muscle at the time of condylar fracture pulls the condylar head and the neck towards the medial direction. That is the lateral pterygoid muscle. Okay, I repeat, the answer is lateral pterygoid muscle. And I want to share a case of my own private practice cases, which they sent it to me. This is a 54-year-old female, which was referred, to me, and they have a pain on the right side of the face. And now you have, when you make a cross-sectional slices, you can see all this, these 6 slices, 1, 2, 3, 4, 5, 6 are these 6 green lines, 1, 2, 3, 4, 5, 6, and these are the parasagittal views. Basically, you will see, there is flattening, bird beak appearance, the sclerosis. That means like chronic inflammation in that area. So whenever you see something like that, or also you see subchondral iliac pseudocyst, that means you will have degenerative joint disease. There's a flattening on the right side. Degenerative joint disease on the right side, and the left side also you can see the same thing: flattening, osteophyte, erosion. So it is very interesting how they look at it. Okay, so that's how I diagnose this as a degenerative joint disease. So basically, they have to go and check for the disc and other areas. And this is a paracoronal view of the same patient. That means you're looking from the front to back or anterior to posterior. There also you can see flattening, erosion, discontinuity in that area. So these two, parasagittal view and the paracoronal view, gives a very good information about how the joint is behaving or changing over the period of time. And for the same patient, it was very interesting. The patient revealed that the patient, is HIV infected. And also, when I'm looking at the scan, I saw a lot of, opacification, or we call it hyperdense area in CBCT. I can see a lot of hyperdensity in the parotid gland region. So the end patient have, reduced saliva reduction, and patient also have a Sjögren syndrome in this case. And we also found, not just degenerative joint disease, and also we have patients as seen, osteoarthritis in that area too. So over the time, you can see a lot. And in the same patient, you can see the spine. The spine is kind of like, not in symmetric. It looks more like asymmetric. There's, flattening, sclerosis, and there's a bird beak appearance in that area. So, and the reduced joint space. That means patient also have neck pain and, also TMJ pain. So we diagnosed this patient as not just, and it was, going more towards osteoarthritic cases in this case. And these patients undergoing treatment and doing pretty well, as based on the previous, conditions and everything. Now let's go to, our area of interest, mandible. Let's start with the mandibular area, and you can see, this is the, CBCT reconstructed pan. You can see there's no palatoglossal airway artifact. And you can see the canal kind of goes like this, superior, and there's another accessory canal. You can see that too. Jeff Price is my friend from North Carolina, so we have worked together on this. And then the other one here, you can see and we call them bifid mandibular canal, or you can also say, accessory canal there. The bifid canal would be a better term for you use this. So, a couple of days ago, I have a case where a patient wants to extract number, 32. And in this, in that case, what happened was, they didn't evaluate the CBCT scan. And at the time of surgery, there was excessive bleeding. And that time only, they came to me and took a CBCT scan. We took a CBCT scan, and there was a nerve injury in that area. Because of that, nerve got exposed, got, injured, and there was a lot of bleeding in that area. So we are evaluating that patient too. And in the mandible, you can also see, how the, you can see, you can put a cross section there, and based on that, if you have selected 6, it'll show you 6, okay? And then you can see this is the, lingual side, and that's the buccal side, and there is a hypodense area, I understand, and then you can also see, there's not that much root resorption. Looks more like scalloping area border. That looks pretty good, okay? And that there's not very expansile lesion. So one of the beautiful thing about CBCT is you can see the cross-sectional views, right? We talked about that earlier. That is seeing the buccal side as well as the lingual side. So there's not much buccal and lingual expansion. Both the cortices are intact. That's good. In this case, I diagnosed this as simple bone cyst because it's just a simple bone cavity. Previously, they call it traumatic bone cyst. They tend to think that it comes more in in boys who are, young boys who play a lot, and then they fall here and there. So basically, the treatment they go when you go to oral surgeon, they will open this area and induce bleeding in that area. And also, if it's too big, they will put some bone chips from the other parts of the body, and that's where you can get healed from this area. Now, another example for this is this patient is a Dr. Guy's case. You can see there's lots of trapecular pattern in the mandible. Usually, the trapecular pattern show like this, but in the other part of the mandible, you see, loose trapecular pattern, those area. So basically, if there's a loose trapecular pattern and but an increased thickness with enlarged marrow spaces, this is a form of hemolytic anemia, and it's also aberrant formation of hemoglobin. Right? You have studied in your basic sciences, and it caused by the sickling deformity of the erythrocytes under low oxygen tension, which leads to their destruction. So this also you can see. So the scans are very interesting. If you know these scans, it can show you a lot of good information. Again, for the elderly lady, this came, and then you can see there's a loss of trabecular bone mass, and there's a lot of like osteoporotic, osteopenic changes you can see, and there's a reduced thickness of bone density and cortical area. So these are the osteopenic changes going on. And once you have the blood testing and report everything done, and then you can call it as osteopenia. Other than that, if you don't have a blood report, you have to call them osteopenic changes. That'll be pretty good. Okay. And the other finding I see a lot, patient who comes in, take a CBCT scan, and in the tonsil area, you can see a lot of stones there, which are called tonsilloliths. These are the well-defined, hyperdense area in the crypts of palatal tonsil region, where you find those calcification in those area. And also, in the mandible, in the parotid gland, you can see, there's a depression in the parotid gland. You can also directly call it as a depression in the parotid gland. That's pretty good too. And you must be knowing in the Stephanie bone defect or the submandibular gland depression, which happens in the mandibular lingual area, and here on the parotid, you can also see on the parotid area where the gland stays. So today is Friday. You just relax. Enjoy your time with friends and family. And stay warm. It's getting colder and colder in Michigan. So beautiful Michigan. So now another one we are going to talk about is CBCT being used in our clinical practices. So you can see when we took the CBCT scan, just next to number 32, you can see a well-defined, like scalloping kind of lesion, which is just next to it, and also like pushing the tooth a little bit, more medially. But it's not really resorbing in those areas, and the canal kind of displays slightly inferiorly, but not too much. So these kind of thing, we call them odontogenic keratocyst in the first differential diagnosis, and it comes about 10 to 12% of the of the odontogenic cyst. I typically don't like this kind of cyst, OKC, because it tends to come back and recurs back, and when recurs happen, it's not fun. So whenever you see OKC, be alert, because it has a high recurrence rate, and you don't want this to happen. And another one is the dentoalveolar complex. You have incidental finding. The patient came, and you can see, the patient. Our doctor wants to know why the tooth is not erupting when the time is right. So on top of that, you can see, multiple well-defined tooth-like entities, or you can actually count them: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And you can also see, the slight expansion of the lingual. This is the lingual side, lingual cortical plate, and buccal is not expanded, but both are kind of thinning and expanded, especially on the lingual side. On the lingual side. So these turn out to be compound odontoma, and you have to remove it because you have to give way for this, adjacent tooth or underlying tooth to come and take the place in the occlusion in the right way. So this is very interesting. I get a lot of this consult from the orthodontic cases. And there's another, finding you can see. There's, you can also see the, root resorption. This is very interesting root resorption. You can actually see in the, cervical area, but it's actually not going all the way into the canal. It just stops there before the root canal. So this is the form of external root resorption, and there's a specific name for this. This is called invasive cervical root resorption. And they believe it's probably because of the trauma, previous surgery, orthodontic therapy. So like goes like so. This is a very interesting type of external root resorption. This is a case which came to me, and our implant surgeon have done a very fantastic implant there. However, our implant surgeon felt that it is something is not right. After he placed it, patient came back with the pain and those area. And when I look at the scan, we open it. These are the cross-section images. This is the lingual side. That's a buccal side, and you can see on the lingual side there's a fragments of lingual cortex. You can see it's broken, and also you can actually see on the other red line, two red lines, you can see fragments of dead bone, which are called sequestrum or the dead bone. So we don't want that, and because of that, the implant was failing, and really have to know why it happened. So we realized that when I saw the scan, there was a previous root canal therapy done on the pan we constructed. The inflammation was there for a long time. It turned into chronic osteomyelitis, and an implant kind of aggravated that area. And what happened was over the time, when I saw the mandible, patient said, I asked the patient, is your mandible kind of like into two segments kind of moving? He said, yeah. A couple of days back, I actually, felt that my mandible is kind of like shaking. I feel like there's a two different segments. And I said, this is a pathological fracture for you. Now the patient's undergoing treatment. So oral antibiotic doesn't work anymore. So they're going and using, IV antibiotics, and the patient now admitted in St. John's Hospital. Another one you have here is the odontogenic myxoma case, where you can see this pan. I don't like the pan because there's a palatoglossal airway artifact 2D, and also at the moment, whenever you see, check the sinus floor. The sinus floor is pretty intact on the left side. I'm checking the symmetry. When I go on the right side, I sinus floor is kind of like irregular, those area that I don't like it too. And I have a beautiful CBCT scan of the axial, sagittal, and coronal. It gives me a very good information about the soft tissue and the bony trabecular pattern inside. It looks more like a heterogeneous or a mixed area of radiolucency or a radiopacity. In CBCT, we use the term hypodense or hyperdense area. And the tooth is also getting displaced. You can see that, right? And you can go slice by slice and check everything. And this turned out to be odontogenic myxoma in this case. Now, this kind of myxoma, odontogenic myxoma, I don't like it because when you take it out, it comes in a gel form. When you take it out at the time of surgery, it flows, wherever it has to go. It just flow left and right. If you don't clean that area properly, what happened was it'll give rise to another odontogenic myxoma. So in this case, you have to be very precise from the diagnostics and to all the way to preparation, biopsy report, and everything. Now let's look at some of the anatomical landmark in the maxillary sinus and sino-nasal area. Nowadays, it's becoming very popular in dentistry because now our dentists are doing, root canal treatment for the upper posterior teeth, where the sinus is involved. If you have a issue in that area, they call it maxillary sinusitis of endodontic origin or odontogenic origin. So they referred a lot of our ENT friends. They refer a lot of cases to us, especially to me and to our endodontics friends, and then we work together. And so before we know these things, we have to know some of the anatomy. Ostium is right here. You can see that. A maxillary sinus is here inside. Sorry about the line. The ostium is actually here. Max sinus is here. Okay. Now, in this scan, you can see that these are pathological part. There's a different, coronal view. You can see a well-defined soft tissue density area in the left maxillary sinus floor. This turned out to be antral pseudocyst. Previously, it's known as mucous retention cyst or phenomenon. During the summertime, it goes away, and during the winter time, it comes back. So basically, you can say it's a more homogeneous, dome-shaped, radiopaque soft tissue density. That's what you see. There's no treatment for this. So what you do is, you watch follow-up and then make sure it's not impacting with the sinus and the tooth area. Now, this is a very, very popular things coming up these days. So our ENT friends are sending a lot of cases where the sinusitis is coming only from the tooth origin lesion. So you have to know exactly which tooth to happen, giving rise to that lesion. You can see the tooth, having the root is kind of producing a lesion there, and there's a sinus floor elevation here. So you don't want those things, and it's good you see those and you treat it nicely, and that where a sinusitis, everything will go away. Now, if you delay the process, what happens is the sinus floor will be broken over the time, and the inflammation will spread from sinus floor to all the way into sinus, and that will become very complicated. Now we are seeing more and more cases like this. Recently, just 2 days back, uh, you know, uh, I gave a CE on maxillary endodontic origin, and there were so many people who wants to learn about this. And the first way you can see is through CBCT, and you can really plan your surgery, treatment, diagnosis, everything. It really helps you. It is not just a tool now; it is more than a tool. You can use it, apply it, and make your life easy and do more cases. And there's a maxillary you can see the anatomy here. The incisive foramen is right here. Okay, that's the incisive foramen, and you can see the incisive foramen right here. Okay, in the exam I'll say, oh, where's the incisive foramen? You have to point it here. Okay, and I do remember that I uploaded the PDF file. In the PDF file, everything is in the right spot. Okay, don't worry about that. Now, if patient, over the time, most of the patient above 60 years, they tend to have a larger or like larger enlarged incisive canal. Okay, if the patient is young and patient have like kind of area more than 6 or 7 or 8 millimeters in diameter, 8 by 8, then you think suspect of incisive canal cyst or nasopalatal duct cyst. Okay, it arises in about 4 to 6 decades of life, and 1% of population, mostly males. We see that a lot. And there's another variation of the accessory incisive canals on the CBCT. You can see these lines. These there are 6 lines: 1, 2, 3, 4. Yeah, 1, 2, 3, 4, 5, 6, 5, and then another 5. That is the 10. So total, in these slices you have 10 slices, and you can see those variation, the incisive canals. You can see. Okay, good. Now, because of the COVID-19 and everything, times are, a little bit challenging, but at the same time, there's a lot of opportunity to grow, learn, and learn the digital system. So that's very amazing how we are, we made a progress, and that's lovely. And we can see there's something called, this is the palate here. In the palate, you can see, there's, well-defined, hypodense area with expansion on the superior and the inferior portion of the palate. And these are mostly median palatine, cyst. You can see that cyst got entrapped in between. So that's where you can see there's the median palatine cyst. I see this too. So please have a look at that. It is pretty common in young adults. Now we will go and we will check some of the other areas. This is the nasal septum here. The nasal septum is right at the center, okay? And this is the inferior turbinate, and this is the middle turbinate. Middle turbinate is right here, okay? Please check your, slides for your confirmation purposes. And you also have another anatomical landmarks. This is the uncinate process, and this is the ostium, and this is the heterosymi lunaris. Now, in this case, this is a normal one. You can see there's a lesion there happening around number 2 area, and number 3 area is number 1 area is missing, and there's actually inflammation going on and going through the sinus all the way. Okay, so you can see that too. And this is a sagittal view where you can see the cyst kind of growing 1, 2, 3 and goes all the way into the sinus. You can see the air bubbles there. That means the cyst got infected and went through the sinus floor and giving inflammation, causing sinusitis in that area. So, and the bone around that is pretty sclerotic in the other views. And here also you can see there's a bubble there, and the bone is thick. And these are multiple OKC in this area. The patient, the story of this patient about 10 years ago, they tried to remove the number 1 area, but they did remove the number 1 area. They did a biopsy too, and they thought it's a dentature cyst, and they took it out and left it, and it gave rise to 3 OKC, orogenic keratocysts. And I told you or orange is not nice. So biopsy turned out to be OKC. And this is another case of maxillary sinusitis and sino-nasal area where you can see this is the CBCT reconstructed pan. And now you see something here a little bit, but it's not really clear. But when you have your 3D view, that is the axial, sagittal, and coronal, you can see the area there, the inflammation and the cystic lesion, well-defined corrugated hypodense soft tissue lesion in the area. So these are the surgical ciliated cyst. They did surgery, and when the surgeon is using the blade, it got transported to the other area in the maxilla, and that's how the cyst started. These cysts are pretty common in Japan. They tend to do a lot of osteotomy or bilateral sagittal split osteotomy. This is just a review of the previous one. You can see this is a patient, previously undergone orthodontic surgery. And orthodontic basically means, you put the patient into occlusion for the class 3 and other areas. And so in this case, you can see the same, well-defined multiple radiopacity on the pan. You can see, and once you have a CBCT scan, you can actually see all these radiopacity are just next to these, plates and surgical screws, and which you don't want it. Okay, those are the stuff. And you can see in the left mandible, all of them are there. You can see there's a buccal side, there's a lingual side. There's not that much expansion. That's fortunately, there's not that much thing. All this green line there are 10 green lines. I think 1, 2, 3, 4, 5, yeah, 10, and these are 10. You can create your own lines. If you want 3, you can make 3. If you're comfortable with 5 or 10, you can go with whichever option you like. I tend to like 5 to 10. Many of our practitioners, they like 3 lines in this area. Please remember the cross-sectional view in your CBCT image will be on exam. And we made a volume rendered images. We shown this to patient and explained it to the patient, and then we took we did our colleagues, we did surgery, and then we removed 17 of those from the mandible alone. So that's interesting. This is a beautiful view of the Himalaya where I used to work before in the Himalayas. That's pretty interesting. So you climb. There's that's the Everest, Mount Everest, and then you can you can have a base camp here, and from there you can go down and climb up all the way up, and from there you can go. It's very interesting. People climb the summit, and what happened was when they're very excited, and most of the time when they come down, they fall and they don't make it back home. But they make it, or what they like. Many of our English friends from England, they come because they get the title called Sir. Just to get the title, they climb. They get so excited they fell down. So it's interesting. Yeah, I wish now there are more security and more the companies are better who take them up, the Sherpas and those people. So they are more equipped. So more and more people climb the Everest. And other thing we talk about the maxillary sinusitis and sino-nasal area is the paranasal sinuses, where in this case this is a coronal view where you can see the sinus inflammation in the the lesion in the sinus in the maxillary sinus, also in the ethmoidal sinus, as well in the frontal sinus. This is your exam question. I'll ask you where all the parasinusitis, pansinusitis is happening. So you have to tell left maxillary sinus, left ethmoidal sinus, and the frontal area too. Okay, please now remember this one. And this is the optic canal, and this is the sphenoid, sphenoidal sinus. The exam question for you. I'll put an area there and ask you what is this, and then this is the median canal, and there's the foramen rotundum. In this slide, the most important one is the sphenoidal sinus. And here also the sphenoidal sinus. I put one image there and ask them which one is the sphenoidal sinus, or what area is this one. So please make sure you know the sphenoidal sinus. And sometimes if patient have intracranial calcification because of the carotid arthromas, you can see the calcification in those area, and that's where you can see calcification and everything in the intracranial carotid artery as well. And so that's good. So these are the all this heart problem, cardiac issue you can see here. And this is actually the calcification of Fox cerebri. You can see in the fox cerebri calcification is pretty important for the one syndrome called Gall-Ghost syndrome, where you will have, calcification fox cerebri, bifid rep, and then you have, on the hands you'll have basal cell carcinoma, and there are some other issues too. So if they come show up like this, your patient, then these are mostly, Gall-Ghost syndrome, and calcification fox cerebri is one of the findings there. And another, that is the ethmoidal bulla. You can see there's the ulcinate process. There's a heta similunaris. And also you can see the concha bullosa too in this area. Just make sure you know this and this area. And there's another example of enteral pseudocyst. And the sinus is fully blocked on this left side, you can see here. So make sure you know this one too. And you see the bone, the walls of the sinus are pretty thick, and these are the areas of the, of the sclerotic bone, and that is exactly chronic maxillary sinusitis. And you can see this is the crystal galley, where you can see this is the ethmoidal sinus, and this is the pansinusitis, which you saw, right? Very, very important features for your exam. Sphenoidal sinus, nasolacrimal duct, you have this inferior concha on your axial view, and this is a sphenoidal sinus. Now it's interesting, if you miss any, tooth-related inflammation or any tumor, any cyst, you're responsible for that. So make sure you know and see. If you don't know, ask help, and we will come and help you. Otherwise, somebody else will catch you, and we don't want to put our colleagues in embarrassing situation. This is the frontal sinus. That is the nasopharynx, and that is the lateral pterygoid muscles. And this is called the foramen Rosemuller, and this is a torus tubaris, you can call it. And this is the lamina propria, you can see, of the ethmoidal bone, and this is the floor of the orbit. This is an important anatomical structure for your exam, because if patient have fracture because of the football and the basketball or trauma or the boxing, the sinus floor, the floor of the orbit is pretty thin. It tends to break, and what happens is like it breaks, and the eyeball kind of like falls down. You may see patient having exophthalmos because of this area. Now there's no base area to hold the eye, and eye pops out. They call it exophthalmos in this area. Make sure you know this one. And then you can also see foramen ovale, which goes from this area, and the pterygopalatine fossa, where you have all this pterygomaxillary fissure and all these important nerve vessels going all the way into the sinus, and that go through the foramen ovale. So if you have any inflammation, injury from your dental inflammation or fracture, or if some implant goes through the sinus and on the top, then the infection goes straight into the cavernous sinus, and there will be a patient will have brain injuries in that area. And also, this is the supraorbital fissure. That's the infratemporal fossa, and that is the sphenoidal sinus. Please know that this is your exam question, the sphenoidal sinus. And you tend to see a lot of calcification in the pineal gland. These are called pineal gland calcification. And don't worry when you see this. You tend to calcify over the period of time. So the older the patient gets, you see more and more calcification in this area most of the time. And you can see, the optic nerves going, you can see this is the optic nerve, you can see optic canals, you can see here, which passes through this. So today, if you have any questions, let me know, shoot me email, and yes, I will try to, record this and put it, upload it so that you can have a look, and enjoy the rest of your week, and the weekend is coming, and just relax and enjoy. Thank you so much.